So I'm welcoming you for the first National Intra-operative Electron Radiotherapy Symposium. So the objective of this course is to understand the basic principles of intra-operative radiotherapy, to understand the indications at the moment for IORT in cancer, for whatever the limited evidence base that we have for IORT, and a brief about how to implement the service with earlier physicists who might be talking about that, and radiation protection issues and safety measures which will be dealt by Claire Birch and Dr. Donovan, and some opportunities for networking and collaborations. So what is IORT? It is what it says in the tin. It's intraoperative radiotherapy delivery of a high dose of radiotherapy to the tumor bed during surgery. What's the rationale for IORT? I mean, IORT has been there for some time, for many decades. So generally for locally advanced cancers, surgery is combined with external beam radiotherapy afterwards in the post-operative setting to treat any microscopic disease and to reduce risk of recurrence. However, giving external beam radiotherapy in the post-operative setting has its own drawbacks. There's usually the delay from the removal of the tumor and the external beam radiotherapy is usually over many weeks, can lead to what we call a repopulation of the tumor cells. The other difficulty is localizing the tumor bed post-operatively, which many of the oncologists will agree is difficult, and that could move us to giving a larger margin for our radiotherapy field, which will naturally increase the normal tissue toxicities. We know there is a dose-response relationship in solid tumors. I hope this works. Sorry, it's not working. But if you see on the x-axis is the percentage tumor control, and the y is the radiotherapy dose. The more dose we give, the better tumor control. However, that also increases the normal tissue damage. So there's only a limit that we can, with the current external beam radiotherapy, that we could increase our dose without increasing the dose to normal tissue structures. Thank you. You can see that the more we increase the dose, the better tumor control, but simultaneously the normal tissue damage also increases. So what are the challenges now with the combined modality, particularly with surgery and radiotherapy? The challenge is to improve the local control, to reduce radiotherapy complications, particularly to the normal tissues, which are sadly around the tumor or nearby, improve the quality of life for the patients. So this is where the IORT helps, because we can localize the tumor bed, and we can target our delivery of high-dose radiation to the tumor bed. Because we could move some of the critical structures away from the target, we could reduce the dose to surrounding critical structures, thereby reducing the late toxicities. This also allows us to dose escalate beyond what we could do with external beam radiotherapy, as we said before, without increasing the dose to the normal surrounding tissue with external beam radiotherapy. Again, the chance of re-irradiation with intraoperative radiotherapy is possible much more than what we can do with external beam radiotherapy. As we know, re-irradiation with external beam radiotherapy increases the morbidity for the patients. For those of you who's not aware of what LINAC looks like, so that's a standard LINAC, which is in a bunker, a shielded bunker, and this is a Mobitron, which is supposed to be mobile. Our physicist will tell how mobile it is. It's got wheels. Just as cross-section of a tumor in the pancreatic bed area. And this is a standard conventional IMRT radiotherapy where if we want to treat the tumor, we give 100% dose there, but you spray low-dose radiation around the body, while in intraoperative radiotherapy, after the surgery, we just localize the tumor bed, and we can give a very precise radiotherapy without any damage to the surrounding structures. There are other advantages of intraoperative therapy. We know the radiobiological effect of single dose of radiotherapy is about 2 to 2.5 times than standard fraction radiotherapy. So an example, 15 gray of intraoperative radiotherapy is equal to 54 grays of external beam radiotherapy. Intraoperative radiotherapy can be given as a single treatment or can be given as a boost either after surgery and can be combined with external beam radiotherapy if needed. And this can also, as I mentioned earlier, reduce the post-surgical phenomenon called accelerated repopulation. It's short treatment time. The setup takes longer, but the treatment is short. I'm sure Adley will explain that. So there are different ways of delivering intraoperative therapy. So one is using low energies X-ray system. It's called intrabeam, which is used mostly to treat breast cancers. We have the high dose rate remote offloading machines. And then we have the electron beam radiation therapy, which could either be having a dedicated LINAC in the theater or having a mobile LINAC in the theater. We are fortunate to have all three modalities. And there are pros and cons of the different modalities, but I'm not going to delve into that. This is just to show how the Mobitron looks like. And just a pictorial representation, thanks to courtesy from Fabian Holman. So we have a rectal cancer, which is removed, and then we can focus and treat that area. This again. So this is after the tumor has been removed, where the applicator is in place. And you can see my surgical colleague is spraying. Do you know what he's spraying for? He's saying, wish the oncologist doesn't ask for a frozen section. That's him he's praying. And his trainee is saying, hope this finishes quickly so I can go home. So what are the indications for intraoperative therapy? There are several indications. The common one is breast cancer. Then you have the recurrent rectal cancers or locally advanced rectal cancers, advanced pancreatic or borderline pancreatic cancers. Sorry. Sorry about that. Then you've got a gastric cancer, which is one of the ones that's commonly treated early in the 1960s. Locally recurrent head and neck cancers, parotid cancers, anterior skull-based tumors, pediatric tumors, sarcomas, and so forth. I mean, there isn't any cancer that you can't treat, but this has got its own indications. And more so with operable recurrent cancers. So the International Society of Intraoperative Therapy has an European registry, which has now collected over 9,000 cases from 36 centers, because each centers are, as I mentioned, there are different modalities, and it's worthwhile collecting this because every center use a different modality, use a different protocols. But it would be nice to have this, collect this data so that it will form a registry trial. This gives an overview of what are the sites that's been treated. And you can see breast is most common in the European registry, followed by colorectal, pancreas, and so forth. Coming to some of the evidence base, I'm not going to go in detail, but these are some of the main trials in breast cancers. The IOERT trial, which used an intraoperative electron radiotherapy. The target trial, which we were a part of the target trial, which is a UK trial, which used 50 kV X-ray emissions. A systematic review for head and neck cancers, which shows that IORT seems to be a safe treatment modality. And these are some of the studies, which again you can see most of these are recurrent cancers. They're retrospective, they are small numbers, but they give a fairly good overall survival and local control, particularly for these recurrent cancers where we know the prognosis is quite poor. And again, the toxicity is fairly acceptable for a re-irradiation. And this is some of the studies for locally advanced colorectal cancers. Again, you can see the toxicities are fairly acceptable. I'm not going to delve into this. I'm sure Alex might talk about the meta-analysis and systemic review for colorectal cancers, which shows despite the weakness, the results suggest that IORT may improve oncologic outcomes in advanced and recurrent colorectal cancers, and so forth for retroperitoneal sarcomas, some pediatric tumors. Again, you can see these are all recurrent cancers where the opportunities to re-irradiate are limited without significant toxicities. Again, some gynecological cancers, bladder, renal cancers, gastric cancers, pancreatic cancers. And again, most of them are retrospective and small numbers. So what do we have so far? The evidence is quite limited. For breast cancer, as we know, both the trials had shown that they are equivalent, if not non-inferior. But the National Institute of Clinical Care and Excellence has recommended that intrabeam radiotherapy is not recommended for adjuvant treatment for breast cancer. But if you look across the pond, the US healthcare insurers considers IORT as medically necessary for certain clinical conditions for cervix, uterine, colorectal, soft tissue sarcomas, and the benefit in other cancers is considered to not been established. So where do we go from here? I know it's difficult to do studies because of the various treatment modalities and different protocols adopted, and these are not a homogeneous group of patients, and hence maybe using something like this, using registry trials, maybe the way forward. So in Southampton, we are fortunate to have the backing of Planets, which Neil Pierce has been a big drive in establishing the pathway, and this is our pathway, so patients are referred from elsewhere. Again, this is completely funded by Planet's charity, and they are discussed in specific cancer MGTs, it's colorectal, pancreas, and so forth. And then if they are suitable for IORT, they're then referred to the IORT panel, which is a virtual panel which we discuss the cases, review them, and it contains a group of oncologists, surgeons, physicists, and then we review this and we accept. Then they get treated. These are some of the Mobitron centers across the world, and here we are. We planted our star 2 years ago, and hopefully there'll be many more centers in UK. So coming to the just the agenda for today. So we have a fairly packed agenda, and hopefully you will find this interesting. So keep calm. Continue this IORT if you can. If you need any help, please do help us. It's to come to us, and we can try to help you in set up a service.